hear it, so let her tell it. People on the streets say Sabrina speaks. Tune into the show, she will let you know. Tell all your friends and family. Real talk is no joke. You get the news straight up from grassroots and concerns. You can hear some people gone. So tell all your friends to tune in to
Good evening, Cayman. I'm Sabrina Turner, and welcome to Sabrina Speaks, your daily dose of clarity, truth, and community insights. Every weekday from 5 to 6:30 p.m., we're tackling the issues that affect you, from national headlines to grassroots concerns. Whether you're in traffic or winding down your day, this is your chance to hear it straight and speak your truth. So buckle up, Cayman. We're not holding back.
This is the show. We gotta let you know. Now we got to go.
And now here's Sabrina.
Good afternoon, everybody. Yes, Connie Palmer said it. She said it, everybody. Hello, happy Wednesday, and welcome back to another episode of Sabrina Speaks, the podcast where voices rise, stories unfold, and inspiration takes stage. I'm your host, Sabrina, and it is a happy Friday. Yes, it is a happy Friday. Oh, no, happy Wednesday. Trick you. That's how I wanted it. Yep, that's right. Hump Day Wednesday. Happy Wednesday, everybody. That's the air body. Yes, it's Wednesday. And it's like a breath of fresh air in the middle of the busy week. Inhale positivity and exhale stress. Happy. And I hope that you have a nice day. Yes. Yes, the show now goes on until 7 based on popular demand. And last night, if I had fooled with you guys, I'd have been here till 8 o'clock. But yes, today is no different. And we're tackling a topic that affects every single one of us from the moment we wake up to the moment that we go to sleep. And this topic that can bring peace of mind, or that it can bring a mountain of stress as well. And what am I talking about? I'm talking about health insurance. You asked for it and I was able to deliver. I was able to pivot very quickly. And that just goes to show you divine intervention. And I am so happy to have, our featured guests in studio. To help me shed some light more on that is Miss Annikki Brown. But look here. If you're really, really loving the content shared here in this space, please follow, like, share, and subscribe so that you don't miss an episode, because we're streaming live on all CMR Facebook, YouTube, and Instagram platforms. And you can follow me as well on YouTube at Sabrina Speaks, the number 12. And on Facebook, you look for Sabrina Turner, Community Activist, and you follow right there as well. But thank you for all of the new followers. I'm seeing you and all the subscribers. You're truly loved and appreciated. 936-8255 is the number to call. You can also WhatsApp me on the said number. That's 936-8255. It'll be on the screen, or you comment live via Facebook or YouTube and join in on the discussion. You know how we do it here. Got to remind you that the content you're about to hear, including any and all discussions or opinions from myself, my guest, or participants, is intended solely for general information and entertainment purposes. It's not a substitute for professional, legal, medical, or financial advice. So I encourage you to consult with a qualified professional for specific concerns. Sabrina Speaks disclaims all liability for any decisions or actions taken in reliance on the information presented. So yes, let us see who is here. Let me remove this. Happy Wednesday. And I was so pleased to welcome Friday. See where I got that from? That was Connie. Connie behaving bad as she got into the classroom. Good evening, everybody. And she's definitely dancing to the intro music. I want to thank Mr. Berman Scott for definitely giving me the jingle. And let's shout out all of our frontline staff, ladies and gentlemen in the front lines. Thank you for your service. Shaka Zulu, hi, how are you? Welcome. No way. You deny it. You're denying it. You threw the rock and then you run, Connie. Hi, Marshall. Welcome, welcome, welcome. Hey, Barbara G. Good to have you with us as well. And Miss Dorothy, good evening to you, my love. Good evening, Marshall. Yeah, between you and Jim, Connie, between you and Jim, the two of you are something else. Cameron, who are you blazing up this evening, Sabrina? Johan hangover. You had enough for him? I ain't blazing up a soul today. I ain't blazing up a soul. But you know, the stone that when they say what? You throw a rock in the pig pen, the first one squeal? I'll leave it right there. But ladies and gentlemen, friends and family of Sabrina Speaks, and definitely all of you supporters of CMRTV.com. It is a pleasure to have you here. And it's Wednesday the 3rd. I got to go here. It's 5:00, right? And everyone knows that Jamaica is having their elections today. And right now, 5:00, pretty much the polls there would have closed. And what I found interesting, and it's no different than here, is that, once you're in line, if you're still in line or within, I guess, those parameters, and 5:00 is here, you're still allowed to vote. Once you're in line by 5, you're allowed to vote. And in regards to ID, voters ID, registered voters are, encouraged to walk with it. But just in case they did not have their ID, and once their name shows up on that polling station, the process, and their name shows up there, they will be allowed to actually vote. So for those who don't have their ID, they can still vote as long as their name is on that voters registration list and their identity can be verified through other means. So again, the similarities to here in Cayman, it is off to the races, definitely, between the JLP and the PNP. You got a green one and you got an orange one. Look, Sabrina Turner has no skin in the game, but I just really enjoy watching it. I've been following it for quite some time, and I really like the rallies. I like the motorcades. I just enjoy to see it, and I know we got some people down there, Caymanians down there too. So hey, to each his own. I want to wish both sides all the best, and let's see the results. Maybe we'll probably get those results by the end of this show. I don't know, but yeah. Those of you just joining us, this episode is Health Insurance 101. Yes, that's what you're in store for. You asked for it and we were able to deliver. Thank you, Miss Dorothy. Must be the lighting. It's a reflection, Miss Dorothy, how I'm feeling inside day by day. To be honest, I'm just very thankful to God. Connie, I was saying no when you said happy Friday. Oh, okay. You picked up on it, girl. Girl, I'm looking for the end of the week. Yes, no. Yeah, I picked it up. But I tried to save myself right there. Cameron, we need to put some stars on them shoulders. Yeah, right. That's one step in the right direction, Cameron. You bad, Yeah, uniform service. That's why I remembered them. That's in my blood. I can't help that. Listen, I'm logging off from you at 6 this evening. I know. No, you're not going to do it. You're going to stay. Or do what I do. Keep us on your TV screen and just do whatever you're going to do with Jamaica from a phone. I usually watch one party on the TV, and then I have the other party because they were having their meetings on the same night on a phone. Tell me how I do it, but I managed to do it just to see what each other is saying. It's fun. Hey, that is all in the game. Yep. So it's just, I enjoy it, to be honest. Where is this taking place? What are you talking about? Not so sure. KB calling in or what? Stop it, Johan. You're rude. Stop it. Too early for that. Sabrina, have on. Oh, I'm not playing with you. Cameron, behave, for God's sake. Yeah, Connie. Just put one on this TV screen, YouTube on the TV screen, and watch something else from your phone. So, yeah, let's get to business because I'm so happy to have my guests in our virtual studio. So, if you've ever really looked at your insurance card, let's say you looked at your insurance card and wondered, let's say, what those numbers all are or what they really mean, or if you've ever had to worry about what happens if you or a loved one had a medical emergency without coverage. Today, I'm hoping with my guests that we'll be pulling back the curtain on this complex but critical subject, and that we're going to break it down as best as we can about insurance, health insurance here in the Cayman Islands. But I want you all to be a part of the discussion. And without further ado, I would like to bring in, with pleasure, definitely Annikki Brown. Hi, welcome, 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 welcome. It is a pleasure to have you back with us.
Thank you for having me. This is my second big love that I'm happy to share with you. When we making this a weekly date,
well,
that's
let me
what's
tell you
happening
something.
right now.
You should. I mean, everyone here loved you, and today's going to be no difference. I'll do that virtual applause.
Very cool.
No, when you look at all these features that I'm finding on this platform, let me tell you, it's fun. I keep doing
Fun,
it, but
right?
it's fun. But I'm delighted to have you here with us again, and based on your knowledge as it brings to this subject to help us navigate this topic, Annikki. And again, I'm hoping that you'll be able to, if questions come, because we're encouraging public participation on this space, that you'd be able to not break it down, but this is like information 101 on health insurance. And like I said, our viewers, subscribers can call us live, 936-8255, or you can feel free to post your questions live on their social media pages that you're streaming from. But we would love to hear with you. But without further ado, because 2 hours go by very quickly, especially when we have great topics like this. And I know you and we could go on for hours, but I think the CEO will pretty much give me a warning letter if this continues, because I've already extended by half hour and we're going into 2.5 hours. So I don't want to get in any trouble.
We'll be fine. We'll be fine. I'll keep an eye on the time as well as you. Don't worry. We're good.
Yeah. So Annikki, let's get started with the basics. We're going to go straight into it.
Yep.
What exactly is health insurance?
Okay. So I'm going to take a step back even further from that and talk about what is insurance. And first of all, what qualifies me to speak about this? I spent 12 years as the country manager for Generali worldwide. And, Generali pulled out of the Caribbean in 2021, pulled out of the Cayman Islands, the Bahamas, Turks and Caicos, and all of the places where we operated. I have since spent some time in the health insurance space still, and I'm currently working in a startup, which is an interesting, very, very interesting place to be, very, very different. It's a little different from what I've done before. But health insurance is a financial product, and people often forget this, right? Insurance is a financial product. So let's just use the example of insurance and then talk about health insurance and what the two things are and what makes them different. This is one of the conversations I have always had on the first day of any new member of staff joining my team. And I'm kind of hoping maybe one or two of them, I think they're all still at work, but at some point in time, anyone that I've trained will probably be able to verify. And by the way, please forgive me. I got paint all over my hands. As I talked about last week, I always do something with my hands, right? Okay, so this is like part of my 101 training. This is day one of working in a health insurance company. I will sit down and have this conversation with new members of staff. Insurance, if you consider the way that we access insurance regularly, we pay an annual car insurance. If we drive a car in Cayman, or if we drive a car, even in other jurisdictions, you will buy car insurance. It's a requirement of the law that you have car insurance. What does that mean? That means that if you get into an accident, if your car is insured, depending on the type of insurance, the insurance company will replace the value that you have lost as a result of the accident, right?
Right.
So it's very, very easy. How much is your car valued? That's a very, very important part of determining how much you can get insured for. What is the value of your car? And what portion of that value did you lose in the accident? And that is what you're able to then claim from the insurance company. So it's dollar for dollar, dollar for dollar. Makes sense, right? And that's an oversimplification. But health insurance is very, very different from that. Health insurance is actually something that is not based on the value, right? So let's talk about that. I have a cold. What do I lose when I have a cold? 2 weeks probably of downtime. I need to pay for medication. Probably need to see a doctor. I probably don't. If my 80-something-year-old auntie has a cold, there's a higher risk, right? Because she's older. If my friend who's an opera singer has a cold, that's a very different experience from me having a cold, right? Because there's a risk to her livelihood. So my voice, for instance, losing my voice to a cold, that cost me nothing, but it will cost her a whole lot more. Another example that we've often used, and this is something I studied. It's so funny because I accidentally prepared for life and health insurance without really planning it, right? So in law school, I took medical law as one of my options, and I loved it. It was one of my favorite things, and I still went on to practice law. But then I ended up in health insurance, and that's been probably the most valuable module I ever studied, right? And I remember one of the examples that my Professor Harvey Teff, I've mentioned him twice now, at the University of Durham. I remember him using the example of a ballerina. If a ballerina breaks her leg, it's going to cost her a lot more than it's going to cost me. And real costs, not just financial costs, not just healing, but the impact on her life. Like her leg is worth more than mine, right? If one of the footballers was to break his toe, it's going to be different than if I break my toe. So using the same type of insurance principle of replacement of value for health insurance is not something that's really possible. You have to use something very, very different, which is where the system of benefits comes up. All right. So what ends up happening is, instead of having a replacement of value, this financial product that replaces value that you have lost in an episode of loss, or in a catastrophe, or in some form of event, what will happen instead is that you will have a defined list of benefits that you will have defined amounts that will be paid out for. There are a couple of types of insurance that work like this. Life insurance is very much like this. It's a defined benefit.
Right.
Another type of insurance that works very much like this is long-term disability or accidental death and dismemberment. Those are very similar benefits that are based on a benefit system, because, we can't put a value on a life. So we define a benefit for the loss of life. So I will buy $1 million worth of life insurance, or I will buy $500,000 worth of health insurance, whatever I can afford, based on the benefit I can afford. That is the difference between health insurance and, say, property or motor insurance, which is other types of insurance that are very, very commonly used in the retail space.
Very
How does health insurance work?
Yes.
And I loved actually meeting with you, because you and I had really good conversations when you were the Minister of Health, talking about how to improve the health insurance system. And I was, I love when we have somebody in that position. I think we do now as well, who is eager to get really jammed up on the technicalities of how health works and how health insurance works. So, of course, these are very different things. Health and health insurance are two different things. I work in an office. I never put on scrubs. What I do does not save lives. Right? What I do is support someone to be able to afford to save themselves. So the way that I often describe health insurance, if I'm going to define it in a simple tagline, health insurance is bankruptcy, the protection against medical bankruptcy.
Repeat that again.
Health insurance is protection, a financial product that protects you against medical bankruptcy.
Looks like that is actually becoming a reality here, because persons can barely afford premiums, and we're seeing the conversation, having been the former Minister of Health, just trying to fund it. Delve into that for me.
Oh, what drives health insurance costs up comes into how health insurance costs are created, right? And that's a great question. Let me just kind of like take it back a little bit, right? If you consider that health insurance is a financial instrument, if I were to describe it, I would call it a money bag. Okay, let's just call this a money pot, right? We have one 25-year-old who's putting money into the pot. That's premium. You have a family of 4 whose average age is, say, 30. The parents are in their 40s, the kids are in their teens. We're going to say they're putting money into the pot. You're going to have a couple over here that there's a retired couple. They're in over 65. They're putting money into the pot. All right. You have a single mom over here who's putting money into the pot. Let's just say this daddy over here falls into an accident, gets into an accident, and he has a horrible accident. And I mean, I'm gonna give some real numbers here, okay? Let's just say he has a spinal injury and he also needs to see a neurosurgeon. Some of that when I first started with health insurance, a lot of these things could not be treated here. And there's certain things that are still going to be sent overseas. Okay. Let's just say he has an estimated need for care that is over $500,000. Very realistic. In fact, that's very low. That's low. For anything with neuro, you're looking at upwards of 800,000.
Wow.
Right. So he doesn't have that in his bank account. He has children to feed.
Correct.
Do you? Do I? We don't have that just sitting around in our bank account, just sitting down there waiting for us to pay. Right. Not the average person who is working in the world does not do that. So what happens is that money is drawn from this pot that is collected. In health insurance, we call this pooling. Pooling of resources. Now, when we see health insurance premiums being determined, what often happens is that pooling is, you're going to see how much we took out to pay for claims for these different families in a year. On an annual basis, we take a look at it in a year. And of course, we have to monitor this on a monthly basis or on a quarterly, depending on how the company runs. And we're going to take a look at it and see how much has come out of the pool. Is the pool in a negative? If the pool is in a negative, we are going to charge that negative plus next year's projected premium, plus our operating costs. So what makes up a premium? There are multiple things that make up a premium, okay? That premium is going to be, the majority of your premium is paid out in claims. What does that mean? You go to the doctor, you hand over your health insurance card. Your health insurance provider is supposed to give you some form of identification. That is usually either electronic or in a physical card. We're moving more electronic these days. A lot of us are trying to go paperless, right? You take that into your physician. What will happen behind the scenes is that they will take your card and they will submit a claim for the amount that you're covered for over to your health insurance provider. That health insurance provider is going to pay the physician. That's how health insurance works. However, if we draw more from the pot than is in the pot, that results in an increase in the premium for the next year. Usually there's a profit margin. Generally speaking, that's anywhere between 5 and 9%. So in general, I'll give you just some general numbers that were thrown around in the industry before. I'm not speaking on behalf of any single insurer.
No, we're just speaking
right? So
in general.
I'm actually really privileged to be able to do that. I don't represent a single insurer at the moment.
Correct.
But 75 cents of every dollar that you pay to your health insurer, every premium dollar, about 75 cents out of that is the goal that we would be paying out in claims. 25 cents is going to pay for rent, utilities, all of your overheads. Is going to pay for your staff. Is going to pay for your admin costs. Is going to pay for your wellness plans, etc. Now, if your health insurer is managing your costs properly, and I'm going to come back to what managed cost looks like, you should be in that 75 cents to the dollar range. Right? 75 cents to the dollar is what we should be paying out in claims. But if you see your health insurance premium going up, that pool in that money bag, that should mean, if everything is being done ethically and according to insurance standards, that means that we have taken out more than 75 cents to the dollar out of that pool.
And what may have caused that?
So what drives up the cost of medical insurance? The simple answer to this is the cost of doing business. There's all sorts of things that are, we have a very high cost of living and high cost of doing business.
Yeah.
But that cost of doing business is going to attack that 25 cents that's on the dollar, right? So that's going to be your rent. That's going to be your increases in your COLA, whatever it is, right? But then the main driver of the raising of health insurance costs, health insurance premium, is healthcare costs.
Okay.
Okay. So what does that mean? That means that if healthcare costs are continuing to rise,
which we're seeing happening globally.
Yeah. If healthcare costs are continuing to rise, and remember there are multiple things that cause healthcare costs to rise. One of those things, and I'm going to talk about the ethical ones, the ones that are obvious. There's going to be new advances, right? New advances in medications, new advances in technology. There's going to be new types of treatments. These new things, generally speaking, cost a lot out the gate, especially medications.
Mm-hmm.
Until there is a generic drug available, that prescription drug that is brand name drug is going to be very expensive.
Mm-hmm.
I've seen the difference recently. I was going to buy some allergy medication, right? And the generic was like less than $10, but the allergy medication itself was in the $30. Like that's a huge difference between, and that's over the counter. But imagine now that is all happening within your pharmacy.
Right.
So the increase of new things as well as the way that prescription drugs work is going to be one of the things that drives your healthcare costs up. Drives your healthcare costs up, that impacts your health insurance premium. However, there are other things that are really not that great. Like, so for instance, we should be protected, generally speaking, in Cayman. We should be protected by the standard health insurance fees, which I'm going to get to because I think I need to talk about the legal framework. But we should be protected by the existence of standard health insurance fees, which is for every single thing that you can access in healthcare, there is a code.
Mm-hmm.
And we generally use the CPT codes. I can't remember what CPT stands for. But for each one of those codes, there is a fee. And it's built into our law that fee is what we're going to pay. The fee was created in 2015, I think it was, last reviewed, 2015. And it wasn't really adjusted. All they did was add new codes. So they review it periodically. Not fast enough for me, in my opinion. Those fees need to be reviewed at least on a biannual basis. We are looking at premium on an annual basis. You should be looking at fees at least close to that. But we've gone many, many years without reviewing those fees and seeing what those fees need to look like. Now, that is not just. I'll get back into the fees because that fees is a big part of the conversation. Standard health insurance fees is a big part of the infrastructure that we have in Cayman that's specific to Cayman. But one of the things that drives up our health insurance cost, which is our health care cost that impacts our health insurance premium, is overutilization. Okay? So why utilization is important. Now, that requires a cultural shift that I think we haven't quite gone into well enough in Cayman yet, right? So this is I'll tell you the story of health insurance in Cayman. Back when I was a kid, when you and I were children, Caymanians accessed healthcare for free.
Yes.
Right? We went to the HSA. It wasn't the HSA, it was the Cayman Islands Hospital. We went to
Or they found you at school because there was public health in schools.
Right? Public health was in school, and it still is to a certain extent. It was really, really good, though. I mean, we had a dental exam. Correct. We had checkups on an annual basis provided through school. Caymanian children then were covered by the government, and I think the adults were covered by their employer. I can't remember what that segue period was. But in 1998, I think it was 98, the health insurance law was passed, which required that employers should provide private health insurance to every one of their employees, as well as give access to their children. So that law came in. Then not long after that, the regulations would have also come in, which outlined, and I think that came in, that came in a lot later. The standard health insurance contract, I don't think was part of the initial law, nor was the standard health insurance fees. So if you consider that before 1998, our people, Caymanian people, were accustomed to accessing healthcare from the government. There was no need for them to say, how much does this cost? Should I be going to the emergency room when I have
They just went.
a pimple on my face, right? They just went, they just used it, which is one of the dangers of a national healthcare, is that there's no concept in the user of that healthcare. There's a disconnection between the user of that healthcare and the cost of that healthcare. So it ends up becoming very, very expensive, right? So, and then of course the government pays that. So Cayman grew, Cayman exploded. Cayman became this huge destination for guest workers. And we ended up in a place where we had a lot of people coming in from overseas, and people needed access to healthcare. And it was acknowledged by our government at the time that we need to make sure that these people do not become a stress or a danger to our healthcare system or to our jurisdiction. We need to make sure they're provided for. Because if we are responsible for all of these people coming in, then we need to really be making national decisions, right? So they made on the basis of being able to cover this. Because one of the challenges with healthcare is that there is an unlimited demand, but there's a limited supply, right? There's unlimited demand for the use of healthcare, but and that's why we have benefits defined. But there is a limited amount of money that we have to go towards this thing.
Exactly.
So government decided to shift some of that burden into the private sector, and allowed for private sector employers to shoulder some of the responsibility.
But are we seeing that working out? Because we're seeing, and just to interject, because that's going into how did health insurance get started here in the Cayman Islands? We're seeing you're dabbling into that historically. But even though that shouldering, so that government wouldn't have to bear 100% of this cost, we're seeing now that some private insurance max you out and then still say, go to Cineco.
Okay. So let's talk about that. How do we max out, right? Let's talk about that maxing out, right? Your health insurer is not going to max you out. Your healthcare provider will max out your health insurance, right? So remember, we have to keep these two things separate in our heads.
Separate, okay.
Healthcare and health insurance. So we talked about the things that drive up the cost of health insurance. One of them was new advances. Another one was overutilization, based on the concept that you don't really think about where you're going. If you consider that you go to an emergency room, the emergency room services are more expensive than if you waited until morning and went to your GP. So that's going to come out of your pot. That's more is coming out of the pot for you than if you had waited to use your health insurance more responsibly, right? The third thing that drives up the cost of healthcare, which is a very unpopular thing to talk about, but it is something that impacts all of the jurisdictions that have any form of private health insurance, and that is provider fraud.
Speak it loud. Speak it loud.
And people, it's so funny because people in this industry are very, very gentle in the way they talk about this, because they don't want to say anything that's going to end up. Insurance people are naturally risk averse. But I've always come from a funny place with that, which is that if you don't say it, then people will never understand that it exists.
Yes.
Right?
And
we
it
have to
is
have the
here.
conversation about provider fraud.
It is happening here. Right.
We used to sit around the table as health insurers. And of course, I've been in this now, 15, almost 16 years. And we used to sit around the table on a monthly basis and talk about claims trends. And our only defense at the time against fraud was our meeting on a monthly basis. So our claims people would get together and say, you notice that the physician is doing this? Do you notice that this is happening with this particular facility? And we would actually also be the ones that would catch abuse, not just in a financial, but also physical, right? And so all of the providers, all of the health insurers would have a blacklist. We had a blacklist of people that you'd have to keep an eye on, because you know that their claims, number one, were not always honest. If you add them all together, If you added all of their chunks of time that they build you for together, it'd be more than 24 hours in a day. Let's just put it that way. Easily. I think we did it with one of them one time. We did it internally and we got up to like 16 hours. And that was just one insurer. So
Oh, wow.
that'll tell you the kind of healthcare fraud that exists. Another thing that came up was pregnant men. And I don't mean trans people. That's a whole other thing.
What do you mean, pregnant men?
A woman taking a man's card, somebody else's card, and the doctor knows. And so this is a fraud by both provider and the member. You're taking the card for this person. It's a man's name on it, but it's your patient is a woman who is pregnant.
Mm-hmm.
Come now, that person is not insured under this policy.
And that's not their dependent, and they just accidentally picked up the wrong card?
No. No. There's no accident. It was fraud. We've also seen, so multiple hours in a day. We had one situation with a physician that would see somebody for half an hour, right? But say that patient had like 5 different ailments. That physician would bill for half an hour for each one of them ailments. Okay? So that's the kind of stuff that ends up coming out of your pocket. Which is why I always recommend, we have a really smooth access system here where you go to your physician, you go to your clinic, you offer them a card. They take the card, and then that's almost the end that you see of the whole situation, the whole financial workings. Right. So for the most part, I think the system is working. Like the mechanics of the system is working. What isn't working is the back end. Mm-hmm. We're not paying attention to how much people are being charged. We're not paying attention to how many surgeries are happening that should not be happening. We're not paying attention to how much abuse we have of medications here. I remember there was a person that I used to work with who was responsible for Generali throughout the world, right? They were responsible for the claims throughout the multiple jurisdictions. And she said to me one day, listen, Cayman is the most medicated cohort that we have on our books. The most medicated.
Meaning that there's so much prescription medications being
prescription medications.
But
so when I saw your ministry start to take on the pharmacy law, I was like, okay, somebody's paying attention. We need something done here because we have an opiate crisis that is very, very, very quiet.
But you don't understand what I took a beating myself and the CMO at that time because of this being brought to our attention. And we're not going political here. This is just a fact because we were on to something with over medication and based on the per capita, how much prescription and in quantities that were being prescribed. And let me tell you something, that was huge against myself as the minister and the CMO because we were on to it. Hold that thought because I want you also, you've highlighted, and I'm seeing your comments to my people who are logged on. I'm seeing your comments and I will read them. When you identified obvious fraud that was taking place, who or what agency were you reporting that to in order for them to be brought to justice? Again, the word accountability, gatekeepers comes to mind. But so we're educating. This is an informative space, and this is educational purposes.
So before I entered the industry, a number of complaints had been made to the Health Practice Commission, to the councils. This is what was shared with me around the table of insurers at the time. And it was a major source of frustration that there was nothing done about it, right? So insurers very early on took it upon themselves. So you see, the problem is, Sabrina, there's not enough. I believe there is a gap in the Health Insurance Act that needs to be closed. There are a couple of them that need to be closed, and we need to be giving the Health Insurance Commission the power to hold health care providers to account. We have the Health Practice Commission, which looks at the way that they conduct their practice, but there is nothing that requires them to do any form of financial reporting. There's nothing that puts them in a position to, and remember, I come from a family of healthcare providers, right? So this is not anti-healthcare provider. I love my doctor. She knows everything about me, right? It's not that at all. It's just a clear, objective look at the system. You will see that the health insurance provider has to make pages upon pages upon pages of financial reports. And then on an annual basis. On a monthly basis, there are reports that need to go out. There on a quarterly basis, there are reports that need to go out, all to the Health Insurance Commission or to CMA or to whoever. On an annual basis, we're sending in our financials. No one is doing that on the other side of this, where the money's being spent. So it's like money's going into a black hole where we don't know where it's going and we don't know what we're paying for. However, we get patients come into us to say, you know something, I went to this doctor with a stuffy nose and he told me I need a septoplasty.
Which is construction of the nose.
Yeah, it's a construction. It's the septum, right? Yeah. Like you have a deviated septum. It means your septum is split. But everyone has a deviated septum. Everyone does. You having a stuffy nose, there are multiple steps you should be taking before you get to surgery. But there's certain providers that will send you straight to surgery, right? So this is where it ends up being so dangerous, right? And of course, so making reports to the authorities have not borne fruit.
Because
what health insurers did, we keep talking about how we have laws but we don't enforce them. That's one of them. And in this particular instance, I think we also do not have the proper mechanism even within the law. So even if we went to enforce it, it would be hard to do it because it's just not really well done. Right? We need to be doing better with that law. That law needs to be redrafted to have certain requirements for health care providers. What I love, the HIC has done very good work, right? Excellent work. Health Insurance Commission. Thank you for keeping me out of the acronyms.
I'm listening.
The Health Insurance Commission has done excellent work throughout the years, right? They've held providers to account to the extent that they can. They've held health insurers to account. They've held employers to account, and they've held employees to account. But they're under-resourced, and I don't think that they've been given enough. They've not been given enough discretion when it comes to the healthcare provider, in my opinion, because this is a fiscal responsibility to be billing properly within ethics, and there needs to be some form of measure around the honesty of the way that you bill.
It wasn't that they lacked funding under my watch. I gave them the funding. I gave them the funding in order to get the resources.
Yeah, and to be fair to them, they've done a really good job with things like setting up. I know that they're doing a portal right now. They're doing a lot of good things. I have always had great relationships with them, even when the Health Insurance Commission would, if there were complaints that they had to deal with. I go argue my point, but I respect the professionals at the Health Insurance Commission. They are the ones who are responsible for. Regulating the health insurance company. So what I'm really glad that they did was, I think it was 2017. It may have been around that time. They put in a new threshold within because they have a lot of discretion. They have a lot of discretion according to the Health Insurance Act to create certain guidelines as to how to conduct business and with the regulations, right? So they amended the regulations to require that a health insurance provider that has been licensed by CMA, they also need to have a approved health insurance certificate from the Health Insurance Commission. Okay. Right? So that put the Health Insurance Commission in a position to jerk a license. Like to say, no, you're no longer approved. You can't be selling health insurance, or you can no longer be doing this. So to say that the Health Insurance Commission has been overstretched, they are actually, the Health Insurance Commission is regulating every single person in Cayman.
That's a huge
When you
cap.
consider, when you consider they are regulating every employee, every employer, the coverage of every dependent, and every health insurance provider and every health care provider, they have their hands full. Every ballot button is accounted for under their jurisdiction. So there's a gap around in the way that the law is written. There is a requirement. For instance, I'll give you an example. There's a requirement in the Health Insurance Act that the health care provider shall accept the card.
So they have a choice. So they have a choice.
No, they don't have a choice. They don't have. It's mandatory. Shall means you must. There is no wiggling out.
But they behave as though they have a choice.
But they behave as though they have a choice, and they can. The reason for that is there is no consequence in the law. There's no mechanism for, say, the health insurance law, the Health Insurance Commission to go and say, no, we're gonna fine you.
Correct.
There's nothing. There's no way to. And don't get me wrong, there have been good reasons for them to not accept the cards, right? If you haven't been paid by a health insurer for 3 months, that's against the law too, right? So the health insurer has broken the law, which should put you in a position to say, I can't do this anymore. Correct. I can't be giving services without being paid. But there should be a threshold written into the law. If you are paid up to date for fully submitted claims in a timely fashion, you should be accepting the card. And this should be the consequence. So that's the thing. That's one of the examples of the things that is currently missing in the health insurance law, in my opinion.
Okay.
Now, I think you asked me a really good question. I don't know if I actually answered it. I went around the block on that one just now.
I don't know which one, but to give you a break, let me read some of the comments here. And
okay, good.
give you a break, and so we can catch back up. We got Miss Ebanks that his comment here. It's a liability because you pay every month without problems, as in most times deducted from your salary. However, when you get sick, insurance covers little or nothing, and if they cover, it takes forever to get paid out.
That's a good one to answer.
Another one. Mind. No, go ahead, so we can take them in small bites.
Can I go back to that one? To that one, please? Sure. Okay, so the first thing is, yes. So the health insurance, yes to some of it. The Health Insurance Act and the health insurance regulations puts the employer in a position to deduct an amount from your salary. So that the employer is required to pay 50% of your SHIC premium to your health insurance, right? To your health insurance premium. And yes, it's frustrating when you're underinsured. So what does that mean? If you're on a standard health insurance contract, that's going to cover very little. That is the basic. That is the lowest thing that's available on island. But it is the only plan that has a certain amount of control over the pricing. So if you're paying less than $200 a month, understand that is something that is being covered by that is a standard health insurance contract, which has a standard health insurance contract premium that is set by the Health Insurance Commission. You can't charge over that without permission from them.
Okay.
But it is the lowest plan. It is the lowest plan, and I believe that it really is a good plan for people that are only needing to, they're only trying to cover against accidents because they're, young, healthy, and immortal.
Because people are saying that it's inadequate. Right now, it's not meeting demands.
The challenge is now, though, that is the plan that's available mostly to individuals. There are very few insurers on island at the moment that are offering anything but the basic plan to an individual. If you are not employed, or if you are trying to get individual cover as an entrepreneur, you will be paying for the SHIC because that's the only thing available to you. Right. However, if you're part of a group and each insurer has a different group size, that's another gap in the law, in my opinion. That group size needs to be attended to, because some insurers are saying they're not taking anybody 20 lives or less. Right.
Oh,
but we understand, on a group plan, they'll treat everybody else as an individual. That's a place that could be fixed. That's a place in the law that could be fixed. So the challenge is, if you're underinsured, you're only going to get the benefit that you paid for. That's the problem. We have a standard health insurance contract that's super low. It is appropriate, I think, for us to have catastrophic cover for that is the basics.
Mm-hmm.
It's appropriate. It's appropriate when you have people that are here for 3 months. It's appropriate that it's a plan that we need to have. There needs to be a minimum, right? But if we are paying for a higher plan, I want you to go back to it again because the last part was a part I was interested in answering, if that's okay. It will only cover to the benefit you pay for. This goes back to the beginning of what I said at the beginning. We don't have a like for like. This is not like motor insurance where this is what I paid out. Sorry, this is the damage that I got, and this is the amount that I got because it's a portion of the value of the damage, right? We can't do that with health. So you're buying a benefit plan. And if you're buying a lower benefit plan, you're only going to get what's on that benefit plan. Correct. The problem, that last part, they take forever to get a payout. That is a problem. That's actually illegal. That's another place where we need to be taking a look at how do we better enforce.
So that's, an enforcement arm now of things.
So our health insurance regulations, and it's a very easy regulation to read. I would recommend anybody to get their hands on that from the DHRS website, the Health Insurance Act and the Health Insurance Regulations. It's a very, very easy law, very easy regulation to read, but it will tell you that in that law that a health insurance company should be paying your claim within 30 days.
That DHRS website up here for the sake of those who want to see it. Here we go.
I think it's DHRS/HIC.
Yes.
So the Health Insurance Commission. So that's Department of Health and Regulatory Services. Right? And the Health Insurance Commission. It should not take you more than 4 weeks. It shouldn't take you more than 30 days to get a payout on a claim that has been submitted. However, your provider has 6 months to put that claim in.
To get paid.
Yeah. So whenever they put that in, then we have 30 days.
Okay.
And for the most part, insurers do pay within that 30 days. It should be an outlier that they don't pay within that 30 days. I remember we were down to 15 or 5 to 15 days with our turnaround time. Okay. And that's where insurers try to compete.
Your policy within your organization at one point.
Yes, the organization that I ran in the past, which has been gone since 2021. Yeah. So you should be paying attention to when that claim went in so that you can start your clock then. You have responsibility. You have to be responsible spending your insurance when you're sick at night.
This is the one about choosing to go to A&E instead of waiting to do or emergency care. Just break that down because
let me break that down, right?
We got so accustomed to just going into back in days casualty.
Yeah, casualty. We used to go to casualty for a hangnail. If you buck your toe, you're going to casualty. No. So I'm not saying that you need to be responsible spending your insurance when you're sick at night. I'm saying that you need to be responsible spending your insurance, period. What that means is if you have something that can wait till morning, there's a definition in the law that of what an emergency is. Sudden onset of threat to life or limb. All right? A sudden onset of threat to life or limb. We generally stretch it a little bit to say if you're in significant pain. If you're in pain and discomfort and you can't make it through the night, go. If you buck your toe and you take a Panadol and you put it up in the air and you feel better, that's okay. You don't have to go there that night. You can go the next day, depending on how bad it is. You have to make that judgment call. But when you see people going into the emergency room because, for silly things that could definitely wait till morning. Oh, I got time now at 9 o'clock. Let me go down there. That's when you have to stop and think, hold on a second. Should I pay $900 for this? Or can I wait and pay $150 for this? Because it's not about your insurance. It's about how much money you're spending. That bag of money that you're putting money into, that's still your money. That's still your money. You need to spend it like it's your money, not just like it's the insurance company's money. Because the truth is, it's still your money. And if we don't have enough to spend to pay for the things that you actually need, you're going to pay for it next year. That's how the premium works.
To be honest with you, I don't think people understand that concept. What you're actually...
We're just pooling your money together. My job is to pool your money together.
But actually accessing healthcare services, there's a price tag. Yeah. So if you can wait until morning and like you use the buck toe that is not like broken or distorted or whatever, versus chest pain and shortness of breath. That's two different things.
That's two different things. If you can't breathe, go to the emergency room.
That's a total different thing. But what we're saying, if you just choose because it's convenient to you to go to emergency room at 9 o'clock in the night because it was convenient to you, not that you were in serious distress, there's a cost that is much higher for going to the emergency room versus walk-ins of the accident and emergency, the walk-in clinics.
Yeah. And
There's
in fact,
costing of using the A&E, accident and emergency, emergency room versus waiting to go to one of the specialist clinics or one of the doctors in the ambulatory outpatient services. There's a different cost factor for where you access service. And I don't think people understood that. They were just looking at it from a convenient process, from a convenient perspective, not realizing that that too is eating away at their benefits.
Yeah, but it's more than just eating away at their benefits. It's also the responsible access of healthcare. If you think about this, right? And I've been in the emergency room for multiple things, right? I've had I have really bad asthma. I've ended up at the emergency room for multiple issues. But when I'm sitting in the emergency room with a flu, right? And I see somebody come in with a gunshot wound, that's when you see the difference. That's when you really see the difference. And don't get me wrong, for me, a flu can be an emergency. And for a lot of our elderly people, that flu can become an emergency. That could be pneumonia overnight, right? So you just need to be super aware of what your body needs in that moment, right? So, and I see, your typical Caymanian, as your head hurt, you go hospital. But that was typical. That's how it was because, it's interesting because that's why I go back to the 1990s before we never had to pay for healthcare. So we didn't have to be aware of these things. So it has to take a mental shift now that we are now in charge of our healthcare spending and we get to say how that works, right? So it does make sense that we have to be wise how we spend our healthcare dollar because we're responsible for it in the end. But one of the things I wanted to say was that you have to remember that trauma team, that your accident and emergency team, they are trained for trauma and accident and instant, like they're trained for casualties, right? So when they're sitting there waiting on call 24 hours, right? And of course in shifts, I don't mean that they're there for 24 hours, for your heart attacks, for your strokes, for your car accidents, for your stab wounds, for your knife wounds, for your burn victims. These are going to be people that are obviously an emergency. Like that's the super obvious end of the scale. But then there's a less obvious emergency, which is that, okay, I have an allergy and my allergy, I have anaphylaxis. That's very close to that type of accident, but it doesn't happen to everyone. That doesn't apply to everyone. So I need to know my own health care. I know that I'm allergic to this thing. And if I take it, I will die. My lungs are going to shut down. I'm going to swell up. I'm not going to be able to breathe. They're going to have to intubate me. Take me to the hospital immediately. That's an emergency. But then when, and then you get down into those more gray areas, which is that, I have a pain in my stomach. I don't know what this is. It feels like it might be a cyst that you can bleed out with a cyst, or you can wake up the next morning and you're okay. Right. So that's like an ovarian cyst I'm speaking to. And of course I'm speaking to the ladies, right? So that right there is a judgment call that you often make. Like women make this all the time. Do I go to the emergency room with the cyst? Is the pain so excruciating that I cannot stand up and I might pass out? Or is it something I can sleep with? I can just take a Panadol and sleep and I'll be okay the next day.
That's only if they know that they have a cyst in the first place.
Right, exactly. So that's what I'm saying, that there's an awareness. But if you are in doubt as to the seriousness of what you're dealing with, go to the emergency room. No question about it. When in doubt, go. When in doubt, go. But if you know that you just you cut your fingernails a little bit too far, or, you got one pimple and it busted and it hurts a little bit, that's not an emergency. You don't go to the emergency room. So the obvious ones are on this end. The not so obvious ones are somewhere in the middle. But the ones down to there's certain things that are obviously not an emergency as well, right? I've seen this comment now. Health insurance is just so bad. I broke my ankle in 2 places one evening, waited until morning. When I went to the clinic in Savannah, they took x-rays, sent me straight to Health City. It was an emergency. I paid $200 each month for your health insurance and never used it for a few years. Still had to pay $1,500 to have the surgery. Okay, so I think this is where we get to talk about. So you're paying $200 every month for your health insurance. That's clearly a standard health insurance contract. There's no other health insurance in Cayman that you can get for $200. I would tell you that an individual who is on a premier plan right now is paying upwards of it used to be, and let me tell you something, health insurance premium has shot up in the last 5 years. In 2021, I think one of my highest premier plan, well, I mean, there were some that the average premier plan would have cost about $800. Now, the average premier plan for an individual is somewhere like $1,200 a month.
Yep. It's
$1,200 to $1,500 a month. And that's an individual. You add family to that, that's a multiplier, right? So you're looking at thousands of dollars people are paying for health insurance. But this is, again, one of those things where, you know, I think I should probably speak to the fact that the market has significantly changed too. In 2020, we had a couple of major emergencies, right? One was that affected health insurance. One was the COVID emergency, the COVID pandemic. The coronavirus pandemic sent all of us home into lockdown. That created an economic emergency. All of the health insurance companies were impacted by that economic emergency, and some of them were impacted worse than others because of the other locations in the world that were worse hit. So, for instance, my head office was in Italy, right? The ultimate head office of the company I worked in. Italy was one of the first places in Europe that was hit by the coronavirus.
Hard.
And not only did they have health insurance, they had a lot of life insurance. So they were very, very badly damaged financially. Then on top of it, you have a lockdown, which has your operation be impacted. We were really lucky because we were able to go remote very, very quickly. But then healthcare providers went into lockdown. And a lot of them started to get even more creative with their billing. Right? Because, you know, it's scary. It was scary. And some of them refused to work. And I understand that too, because you're putting your life on the line. It was a pandemic. It was a really, really scary time. Right? But it's one of the things that is, I just got a little distracted. 1 second. So one of the things that happened was after the coronavirus pandemic started and all of these things started to happen, you also started to see the cost of healthcare increase and the utilization increase, because there was a period of time when nobody would go to the doctor because it was shut down. And then all of a sudden, when we were let loose, there was a flood to the doctor. So it was a really uneven year. It was up and down and up and down. And then you started to see the impact on staff. We actually lost 2 colleagues that year, and not to COVID. But we were in a, you know, of the 7 insurance companies, two lost their heads that year. And then, of course, Generali pulled out of the market. So this whole market has seen a lot of upheaval on the ground of how we operate because of Corona, because of COVID, in the actual numbers, but then also because of the impact of changes in leadership and they're pulling out of one insurer. And you know, it's so funny because I did not realize, I mean, I guess I knew, but I had expected my competitors at the time to be preparing for Generali's clients to enter the market and look for them. But because at the time, when Generali announced the exit, it was like an 18-month period of time in which our clients were, given to be able to move on to different insurers. And just to be clear, I didn't work for Generali directly. I worked for an agency that represented Generali. And I say that for good reasons. But what happened then was that those clients all had to find a place to go. Right? So you're talking about several thousand people needing to find health insurance. So they flooded into the market and went to all of the other insurers. Some of them were ready to receive them, but some of them were working under some very archaic technological circumstances, and their infrastructure was already being stressed by their existing client load. And when they got flooded by this influx of new clients, It broke. So then you start to see the knock-on effect,
Mm-hmm.
right? And some of them also were trying to technologically advance at the same time as absorb this new level of client, this new group of clients. And you saw the whole market go through a major shakeup in the last few years. So you saw a lot of increase in premium. Costs went up. Healthcare access drove costs up. I think also COVID itself drove costs up, obviously, because not only did we have to deal with the initial COVID deaths, which we did cover, even though the law clearly said that we would not be required to cover it. I'm coming back to that. I hope that's another thing we need to change in the law. In the law, there is in the regulations, in the list of exclusions on the standard health insurance contract, it said that the health insurance company would not be required to pay for any health care that you would not be required to pay for if you did not have insurance. That's not clearly written in the health insurance regulations. I can pull it up, because I actually pulled them up in advance of this call.
Mm-hmm.
And I'm going to find it for you. I'll tell you which regulation it was. It's a part of the standard health insurance contract. The standard health insurance contracts exclusions.
And then we noticed an increase in mental health services being needed as well.
Of course.
On persons who were not able to access continued care. We saw where their ailments worsened during that lockdown phase. So you would understand now how that could impact one's illness or ailment because of not being able to access healthcare. So it's blown up by 2 years, in many cases worsened, and God forbid, some may have actually had an early demise because of that.
Exactly. But I found the exclusion charges which the insurer. Okay, so this is exclusion 20. Benefits will not be provided in connection with charges which the insured has no legal obligation to pay, or for which no charge would have been made if the insured had no health insurance cover. It is part of our public health law that health care be provided even if you do not have health insurance.
Yes.
In the case of a pandemic.
Yes, it is. And it's under health. Ministry of Health.
I think it's important for us I remember clear as day. We had a meeting, I think the Thursday, we had an emergency meeting the Thursday before lockdown of all of the health insurance companies, in which we all decided that even though the government was going to pay for COVID, and even though the law said that we could be allowed to not pay those benefits, we were going to pay for it.
Oh, bless your heart.
So it was a decision that was made at the Health Insurance Standing Committee. I was the chair at the time. We had that meeting the Thursday before lockdown to say, and we went through roll call. You gonna pay for it? Boy, I need to ask my head office. You gonna pay for it? Yeah, we're doing it. Aetna throughout the US had already made a decision. They were going to do it. Britcare decided they were going to do it. Generali decided they were going to do it. We all decided we were going to pay. And you see, there's good peer pressure too, right? Because if the big ones are going to, the small ones can't really get away with not paying.
Correct.
You know, like you have to stand as an industry or not at all. So we decided in order for us to be good corporate citizens to a jurisdiction that had allowed us to participate in this system, so carefully put together this system of healthcare, it would be to everyone's detriment, including our own, if we did not pay for health insurance, pay health insurance benefits for COVID.
That brings us then to this topic of insurance provider relationship. And that spoke a lot at a higher level. So let's talk about that relationship between the health insurer and the health care provider. Okay. So let's look at what parts of the law applies to this, and what about providers who refuse outright? I know you dabbled into this to accept an insurance card. You dabbled a little bit, but then we took a little break and we went into some other stuff.
So let me pull up the law. I have the law in front of me. I'm going to give you the exact section of the law. It is the Health Insurance Act 2021, revision.
Mhm.
I'm going to find the section for you because I'm pretty certain it's in this part. It's what we call assignment of benefits. So if you consider that a health insurance product is a contract between a client and a health insurer, it is not between the client. Sorry, it's not between the health insurer and the healthcare provider. It's between the client and the health insurer. Right? So you, Sabrina, have health insurance with XYZ provider.
Mhm.
That contract is between you and them. There is no benefit that is connected to the healthcare provider.
The doctor.
Right? To the
The
doctor. But there is a section in the law that speaks to what we call assignment of benefit.
Mhm.
The assignment of benefit system is what we use to be able to pay directly to the provider. So the
Mhm.
provider takes your card. There's usually a section on the claim form that says that I assign benefits to my provider. And then the health insurer will pay to the provider because the client has assigned benefit to the provider.
Mhm.
All right. So I'm looking for the section in the law. I'm looking for assignment. I actually think it might be in the
When you're looking for that,
Yes,
I'll just put a question up on
found
the
it.
screen. But you can continue.
And it's actually in the regulations, Regulation 15, Rule 4, where a person shows his identification card to a healthcare facility or a registered medical practitioner in relation to a medical benefit that is covered by a contract of health insurance and provided to him by the healthcare facility or the registered medical practitioner. The healthcare facility or the registered medical practitioner shall, and this, remember,
Again.
this is a mandatory something, shall.
Mhm.
When you say shall, it means it has to happen.
Mhm.
The registered medical practitioner shall accept the identification card and verify that there is an existence in a contract, a contract and benefits therein is issued by an approved insurer to provide cover in relation to that person. I soon translate what that means. And where the contract exists, any claim under the contract in respect of a covered medical benefit shall be deemed to be assigned to the healthcare facility or the registered medical practitioner, as the case may be. So what does that mean? That means a provider is required to accept the card, to look at the card and contact the health insurance company, whether it's through their portal or on the phone or whatever it is, and confirm that that person is covered today. Because the thing with the ID cards is that they don't have an expiry. We're not trying to issue ID cards every year because we're not trying to put plastic out into the world. They don't have an expiry on them. They also don't have your photo on them. And it's not all sorts of data protection rules around this, right? So I always advise a healthcare provider, when you actually get an ID card, also ask for a photo ID to make sure it's the same person so we don't end up with a whole mix up with people using
with a pregnant man.
Right? Simple things. Simple things. Simple things. Give me your ID. Let me see how you spell your name. Whatever. But then the next step that the health insurance provider is required, healthcare provider is required to do is to contact the health insurer to make sure it's covered. That way you determine whether or not you need to take money from this client. And usually when you call the health insurance company, they will tell you this person is covered for this much. This is how much you should collect. Right? So that's required in the regulations. And you're supposed to accept assignment, which means that if there's a certain amount that's covered by the health insurer, you're supposed to bill that health insurer, put that claim into that health insurer for them to pay you. You have set up assignment. Assignment's actually required, and it's in the law. It's in the regulations, right? So Regulation 15, let me tell you again. Regulation 15.4. It's your identification card. Talks about your identification card section. So but I also have a lot of compassion for the provider who decides that the health insurer who has not paid me within the 30 days, which is also required by the regulations, if they haven't paid me within the 30 days of me submitting my last claim, and I'm taking the card. But that is not something, there's a gap in the law that needs to allow for that. That needs to now be documented within the law.
It seems as though there are a lot of gaps, and it's going to take, it's not something that you can just say, we want this. We understand the the process that has to go with legal drafting, public consultation, getting stakeholders, and getting feedback from the end user plays in part of this. But the key is actually getting the right people around the table in order to invoke that, to get the wheels going. And the wheels have started turning, but it's not turning fast enough because people are getting sick. People are feeling that they're not getting value for monies for the premiums that they're paying. And we're seeing also, and I got to use this word, the unscrupulous fraud that is coming, and we're just not seeing them take to court. But yet we have aired here today that it's happening. That would frustrate anybody.
Yeah.
I'm
But you
not
know,
sure.
I think rather than, you see, I'll tell you what it is, right? There's a challenge with this part of governance because it is so technical. And I find that healthcare is such a technical subject.
People just want to know.
It is
if
difficult for someone.
I want to get help. I want to get care. I don't want to go through the bureaucracy. And if I'm paying a premium, as Sue says, and you're telling me this is what I still have to pay out of pocket as a retiree, I think more needs to be done to address a lot and to hold, to pretty much stop those gaps, or
to stop the gaps. I agree with you, but this is what I'm saying to you now, is that it's not as easy as you think it is. It takes the understanding. I am really grateful to work with the Health Insurance Commission, the mature Health Insurance Commission that it is today, because the Health Insurance Commission started out with very little experience in healthcare and not in healthcare. They had healthcare experience, but not a lot of health insurance experience. But they've really grown in my period of time that I've worked really, really well with Mr. Conley, with his team. I have a lot of respect for his team. In particular, there's a young lady there by the name of Melissa Berry, who has been one of the strongest inspectors, and they have a lot of new inspectors right now who really jumped on and done really, really good work. I think there's a lady by the name of Jackie Terry. They're really, really good learners, but it's such a technical subject. You see, this is my 101. I don't even call this my 101. This is my 100.5 in my training for my staff. Right? We haven't even gotten into what captives look like. What is a loss ratio? What is a pooling point? Like, these aren't things that we even get to talk about because it's such a technical subject.
But it's sad,
and so the lawmaker that comes in for 4 years, it would take them 4 years of full dedication to understand what needs to be done.
You're quite right.
And the lawmaker responsible for health insurance is also responsible for healthcare, which is also in a whole lot of trouble, right? So there's a lot of I have compassion for how things have gone. I see the reasons why they've gone that way, and I'm not happy with how they've gone. Right? So there's a balance that I have to strike with that, because I also would not want to be in the minister's shoes. I said this to you when you first became minister. I'm like, I am so sorry. I'm not jealous of the shoes that you have.
I tried.
I feel like health is such a technical topic, and that's why doctors go to school for 10 years, 10, 15 years before they qualify to do that for a year. So making decisions, you have to really have very good guidance, and you have to have a very good plan as to how to navigate all of the intricacies of healthcare. Now, of course, this is not healthcare. This is health insurance. Distinguish those things. This is the financial product. Now, I love this question that came up here that you just have on the screen. Interesting topic. I have a question. Should an employer provide an employee who is covered under their spouse's health insurance plan with the monetary equivalent of a 50% of a standard plan? Okay. So this is a little bit more nuanced than the question. I think I know what the question is coming to, right? So in the health insurance regulation, I'm pretty sure it's the regulations. Let me check this again just to be sure while I tell you this. An employer is required to give access to health insurance cover to its employees. And it's required to pay 50% of the SHIC premium for the employee only. Dependents to that person, to that person who is that employee that is covered by that employer's plan, those dependents are required to be given access. They're allowed to apply, but that money has to come from the employee. It can't come from the employer, right? What gets tricky is it an employed spouse or is it an unemployed spouse? They're required to give access to an unemployed spouse, not necessary to an employed spouse. So you'll see some employers actually understand the law. And I used to work with quite a few employers to like guide them in how to set these things up. And the decision was made by several of my clients that we are not covering employed spouses because we're not required to do so by law. And sometimes what will happen is that an employed spouse needs to be covered by their employer because that employer is legally required to pay for them.
Uh-huh.
But what the listener is questioning here is a very nuanced question, because I think this is another place that the law is not super clear, but I interpret it this way. I'll describe how I interpret it. And of course, I mean, I was part of the group of insurers that that consulted on the drafting of this law when I was very, very early in my career. It was the same year I actually joined. And I came straight from the law firm into this law discussion. Oh, it was heaven for me to get up in this conversation. I enjoyed myself. But, you know, it was negotiating and planning and talking about the consequences of each of the changes to the law. And one of the challenges that we have is that we are required to cover unemployed spouses. But later in the law, it says, and I think it's in the regs, it says that an employed, I'll tell you, I'm going to find it. A couple may choose which insurer covers both of them, right? So that gets a little confusing, because if the employer is only required to cover unemployed spouses, this is what it says. I actually found a section where an employee and the employee's spouse or civil partner, because the act had to change to include civil partnership, are employed by different employers. Each employee may, subject to their employer's agreement, elect which employer shall insure both of them, or whether they shall be insured separately by each employer. So it's giving the choice to the employee subject to the agreement of the employer, which is why I think the employers get away with saying, hey, we're only covering unemployed spouses, right? But then the question is, should the employer be required? So, okay, let's just do it this way, right? Annikki, and let's just use Sabrina. Sabrina and her husband. Sabrina's employed here, he's employed here. They're two different places. Let's say Sabrina has employer A and her husband has employer B. You all get to choose whether employer B covers both Sabrina and her husband, or employer A covers both Sabrina and her husband, if the employers will cover employed spouses. If one of you is unemployed, that other employer don't have a ground to stand on to refuse you access to their insurance plan. However, if you are both covered by your own employer, that is obvious. Both employers are handling themselves. Both employers are keeping their responsibilities and they're paying for their insurance premium. Where it gets confusing is that if both of you are employed, but one of you again goes and gets insurance with the other, so you have a family plan with employer A.
Right.
Should employer B be paying employer A back for what they're paying? Like, should they be contributing? And in my opinion, yes.
It's almost like one is getting a free ride. One is getting a free ride. One employer is getting a free ride.
But some employers think that they can get away with it. And actually, that is not the case. That is actually within the law. I'm going to find it for you. I don't think it's a law. I think that's actually the regulations, where it simply says that you are supposed to be paying for your employees 50% of their SHIC premium.
Gotcha.
And I'm going to search.
We got a caller on hold. I think she's still here.
Nice.
Michelma, good evening. You're live.
Good subject. A little bit different about insurance, but listen to me. What I want to ask. Okay, if a person took out a life insurance for somebody, but they got sick, right? Okay, but I can say, okay, apparently they claimed that but my husband took it out for my son. I didn't know nothing about this, but I got something in the mail. It was the letter was sent out on July 25th, 2025. It had the envelope got 3 stamps that were stamped from the post office 31st of July 2025. Then it got another stamp August 5th, 2025. I got it several weeks ago. But I called, right, because I didn't know nothing about, because we kept saying after he gets sick, people keep asking me, well, he didn't have insurance, he didn't, but I never know nothing about nothing. Apparently, he took this out. He must be used to keep the stuff at airport, and I think, because he can't even remember nothing, but I think he took it out with Mr. Hag Borden, so you know that not today. Manufacture life. And this other insurance, I called the insurance company, but I think that they were negligent because, okay, what he used to do, right, because I had insurance with the same company, and I used to pay it when I was working, but after I stopped working, he took it over, and he had these standing orders with the bank, right? Every month, these monies used to come out to go to one insurance for my 2 kids. Well, we still got ours. Mine was took out from 1990. Imagine I took that out, and he was paying it. They made mine. Well, that's another story, but this one I want to find out about. So, okay, they send this letter the other day. Okay, what I'm saying, he got sick, right? Apparently, I don't know how long they were receiving monies or whatever, because when I called now, they're telling me, I thought that there was money in it. Now I glad thinking from time this was out. I had good money, thinking I could get stuff that I need to do out of it because it was telling you. And then when I called, I found a way to see if I find anything about any insurance, and I never find nothing. I look in all the stuff that he had there with me, all our papers and everything, and I can't come across nothing. So I called the insurance. But listen, and I can call, but this is what they say, redormant account notice. Okay, if they had all of this information for us and stuff, why they couldn't probably notify you before? Because if I had known about it, I probably would have kept, paying it. And it says, you are hereby giving notice that, and I'm calling the insurance company, that the SLCI, I don't know what that is, holder the policies in your name being policy number and whatever, then it says, which is now classified as a dormant account under the dormant account law. 2011, the law. Then it got to remove the policy from dormant account. That's under the law. You may correspond with this SLCI in writing concerning the monies held or otherwise indicated and interest in the monies as evidenced by a letter to the SLCI where the policyholder is deceased. Whether the deceased, executor, administrator may write to the SLCI, including his or her interest in the monies held. And then afterward, they say they're giving us notice giving us time till December 31st, 2025, and if not, the money won't be correspond to some general revenue, and it wouldn't be able to be recovered. So
so it'll be forfeited.
Yes, and listen, so I think it is money now, right? So I looking after, well, they send me this. I think I got the policy number on this letter. So if I call them, because like I say, he's sick, he remember nothing. I'm his mother, I'm his secretary, I'm his lawyer, I'm his fiancé, I'm everything. So I called the insurance company, right? And the girl know me. I call her up, which I know the person that sent this to me to, and I call her up. What she gonna tell me? I asked her, I gave her the number. She pulled it up. I said, what type of insurance was? She said that he had it for my son, Julian, it was a life insurance. I said, here again, I didn't even know nothing about that. Then I said to her, I said, and who was the beneficiary on it? She said, he was the owner and he was the beneficiary, right? Guess how much money it is that they want? Because she said that, I guess why it went dormant, but then one payment, she said, maybe before it went dormant, they had received it. So now when CMA pull up something, that payment was paid, so they want to reimburse that back to him that they can close it But listen what the payment is. Because I had to last $57.88. That's what they calling you about. And what I'm saying, I feel that it was negligent on them because, okay, this policy over there, I didn't know nothing about it as his spouse. My daughter didn't know nothing about it. My son didn't know nothing about it. He went and take it out apparently, whatever. So this is what I that he normally do hide things for me, but why hide that? But when they see it,
But Ms. Shelma, I think I know what's happening with you there. To be honest with you, life insurance is very different from health insurance. It's not something that is completely transferable, and it's not something I would be able to speak to specifically without seeing your policy itself. But my recommendation for you would be to take a look, see if you can get access to the policy itself, and see if there's like a dormancy clause, because it sounds as though there's a lapse. There was a period of time that you were supposed to pay, and especially if you forgot that it existed or you didn't know that it existed. They actually have a right to terminate after a certain number of I think it's like 3 or depending on the policy.
But it happened with my account credit union. It's not,
Yeah, it is exactly. It's very similar to banks. It's very similar to the banks, right? So the thing that I would recommend, though, if you need support around this, like you have to remember that health insurance is regulated. The conduct of health insurance is regulated by the Health Insurance Commission, but the conduct for life insurance would have to be, it would be CIMA. You'd have to reach out to the insurance department at CIMA, at the Cayman Islands Monetary Authority.
My point. Why they didn't try to find out something? They just leave it like that, and I will try to notify nobody or nothing. I mean, that to me, that wasn't right. That's crookedness.
Well, that's exactly the kind of thing that you could complain about, like not having a notification, not receiving a notification. That's the kind of thing that you complain to CIMA about.
This was saying nothing, and then listen to mine. Okay, I had a life insurance, and first I had him on it, but after he told me take him out, so I put my 2 children. But that was paying. But listen to me now, that used to accumulate. They had a thing called cash value and dividend, and I used to go and get the little dividends. I used to tell them, I said, I don't want nothing that the policy accumulate that I have to pay back. And I never ever get $2,000 out of that yet. Sometimes I get maybe $300, $500, maybe $1,500 the most I ever get out of it. When I went one time now to check on some, because they sent me this letter book, I had all this money, so I went to try to get, so come to find out, they claimed that I had a loan. I said, but who take out the loan? I never signed nothing for no loan. I said, because I tell them I didn't want nothing that you had to pay back. And every one of the people from one day, but some I'm still living in, didn't know I used to tell them that. But afterward, I understand that it had 3 people up in there that they find out was stealing out of people policy. And like I tell them, I said, they could fraud my name, either called just the S. Martinez. And they said, one of them even admit that they had stole the money, and then the next one, and I God forgive me if I'm judging wrong, but I think that's what happened to mine. They saw that money there and saw that I wasn't coming back and getting nothing, and they steal it. And then my policy gone, and from 1990, I had that out. That should have been a good policy. Now you can't get them policies no more. So to me, all the insurance, whether it's life, health, house, everything is cut.
Thank you,
girl. It's good when you pay them, but when they gotta give you anything, it's always a foolishness
to get back.
Insurance. They made that. The man first made that laptop that I want to. I don't got that now. Paying out every month. And one old baby John went and messed that up. Made that lapse now. If anything happened to my house, I'd be out in the bush with one hand in front and one in back, and mosquitoes eating you.
Let's just leave us there with that. That's a lot for Annikki to wrap her head around. And
nobody should take nothing out with them. They should go as a pity that you have to mess with them.
Yeah. Thank you for your contribution as usual, Shelma.
Somebody said they got any little money, drill a well in your floor in your house, under your bed, or big one hole outside, and put it that and stuff that when it rains, don't get that. Make sure nobody do know where it is with some padlock, some keys, and when anything happens to you, you will dig them on it up and pay what you gotta pay.
Leave us there, Ms. Shelma. Thank you so much.
Ms. Shelma. Thank you for that. I think I have some thoughts on this. First of all, I mean, Ms. Shelma's speaking to a type of insurance that is completely outside of my
of this
outside of my scope. But there is a challenge, right? Where there's a lot of so there's a insurance is often made out to be the big bad wolf, right? The or the crooked one, or there's a stigma around insurers, right? I actually have on my notes right here to talk about Luigi Mangione, because Luigi is such a iconic figure in the world right now. And it's interesting, right? Because first of all, I can't speak to the property stuff because I don't even know anything about it. Health insurance is so specific that it's very, very separate. Like we are very, very focused on first of all, benefits insurance specific to healthcare. So a lot of the knowledge that we collect is far more technical, right? So when an underwriter is looking at your application and they're trying to figure out how to price your coverage, et cetera, they need to know what your conditions are like. So it requires a certain amount of technical healthcare knowledge to make certain decisions, right? So and of course, I come from a healthcare. When I say healthcare background, I mean cultural, right? I was raised by the HSA. I grew up in the HSA, right? So I was one of those nurses' children, and it's so funny because I have so many friends who their moms are also nurses. And it seems like there's a type of person that a nurse raises. Sabrina, I don't know if your kids are like us, but so there's a different culture, I find, in health insurance than there is in property insurance, because I think we, just like the general public, often blur lines between like what is our purpose. We forget sometimes that we're not a healthcare provider, and we behave like one, right? We're not a healthcare provider. We offer a financial service. We offer protection against medical bankruptcy. But we've adopted a culture that is similar to healthcare, which requires a certain amount of bedside, not quite bedside manner, but a certain level of service, a certain level of understanding and hand-holding and support. And one of the things I used to tell my staff whenever we used to train, right, is that sometimes you're going to get very angry. People call you on the phone, and you have to remember that almost every person that's calling you angry is scared. Healthcare is a very scary thing. Healthcare and money can be a very scary combination. So we need to be approaching these things with compassion, because anybody that's coming to speak to you with a tone of voice that is unpleasant, it's because they're scared.
They're not
right.
rude.
So
Yeah, they
it's
are.
not
That's
that they're
fair.
being rude.
They're fair.
I had a client come in who had not been paying her health insurance, and we had to cut her off because our law, the Health Insurance Act, requires that you terminate people at 45 days after your bill, right? And I remember she looked at me, and she didn't come in to see me. She was sitting in the waiting room, and I walked in, and I had just come in from a meeting, and I was smiling, and she said, "I don't know what you're smiling about. I don't believe that people that work in health insurance deserve to be happy." It's like, okay, that is someone who is very upset and scared, right? So, but then I also saw this whole thing happen last year with Luigi Mangione, where he committed murder in broad daylight, and he shot the guy that ran one of the CEOs at United. And it struck me, first of all, I had such a mixed emotion in that moment. And I remember walking into the office that I work in with my colleagues at the time, and we were, it was such a strange moment, because first of all, we had to acknowledge that in the US in particular, there is a predatory nature to the way that the healthcare system has been set up and the health insurance system has been set up. So there was an acknowledgement that there is a pain that drove that young man to do that, right? There's an acknowledgement. And there's an acknowledgement that Cayman actually has a very different system where we have, sorry, that's the Rottweiler, where we have, come here, Papa. We have a healthier balance between public service and private provision of health insurance, right? Without that public service, that private goes rampant. or it's not, or there are people that fall between the cracks. And I actually have on my notes, there are a couple of people I wanted to talk about that are vulnerable populations, that there are gaps around their cover, right? But there is so my feelings in the moment when the whole thing happened with Luigi Mangione, it's so funny because he came up this morning on my feed because there was a BBC, I sent it to you, Sabrina, the BBC article where Shein used Luigi Mangione's face to sell clothes. And I'm like, oh my goodness, these people are nuts. But you have to have a sense of humor at the world right now, because I think everybody going crazy.
Would have to be.
But there's an acknowledgement of the pain that drove that action. But I immediately, my mind went to the people that I have worked with in the US. Right. I immediately reached out to a family member of one of my friends who was a CEO at one of the other companies, and like, hey, I just hope everything's okay with your family and that your dad's okay. Like, this is scary stuff. He's like, and it's like, it's a small circle of people, but I believe that both of those people were victims of a system that wasn't working. And I mean, Luigi and Brian Williams, I think his name was. But in Cayman, we have a huge opportunity to get it right. And the reason that what makes it cool is that first of all, we have a culture of public-private partnership. When I say public-private partnership, I mean the system is set up. We have SEMA and HIC regulating. We have the Health Practitioners Commission regulating. We have the regulation side of it. We have the private provision of health insurance, which is cynical. And then we have the public provision of health insurance, which is cynical, public provision of healthcare, which is HSA. And then we have all of these private pieces as well. So there's we have a really rich ecosystem that I feel is very rounded out. We have a huge opportunity to get it right. We also have a huge opportunity to get it right in another way, in that we are so small. Like, it's stupid that we would get it wrong. Like, we are so small that it has to be possible to get it right, right? There's we get an opportunity to be like to create a balanced system, and I think we've done very, very well. When you see what the NHS is going through in the UK and what people in private health insurance is going through in the US, and you see the middle ground that we stand on, you realize, you know what, we have done very, very well, very well. But there are gaps, and there's ways that we can improve, and there are things that we can be doing better. And I feel like it's just that it's so technical and it's so scary, because it's so technical, that it ends up not being prioritized in the way that it could be. And I see opportunities, and we've seen a new change in our government. I'm hoping to see that we have the changes that are going to be positive for all of our people, that makes sense, that is going to be sustainable, that's going to work for us.
It's pace that is the problem, because people are feeling you're not doing anything. And that goes back to this question that Lisa actually posed from yesterday, Lisa Brightly.
Yep, I see it here.
Yeah, so she's asking about that the grandfather law within the health practice law.
I don't really understand it. I actually pulled up the Health Practice Act just to see, because generally speaking, when you see a grandfather law, it would mean that an older law has some form of continuation, even though a new law has showed up. So I actually don't see, and this law.
Because she said yesterday on yesterday's show, and I captured it from a screenshot, to see how health practice insurance covers goes from way back in many years ago. I understand that there is something as a grandfather law.
I don't actually understand the question, because that could actually be about a couple of different things. It could be speaking to the fact that the healthcare providers, the health practitioners, are required to have their own insurance against malpractice, right? So their malpractice insurance. It could also be speaking to whether or not the Health Practice Act I think the Health Practice Act requires that they have, that they actually have insurance. Let me just search it real quick, because I pulling up all my laws for it today, and I get legal advice.
No, I'm hoping I'm hoping it's informative, and I'm hoping that we're able to cover what people are looking for, because as one commenter, one listener commented that there's so much parts to this insurance, and I'm hoping that people will understand the different tiers surrounding insurance. It's not just, insurance. There's multiple little pockets or buckets, as you may want to actually describe it as being.
Yeah. So I'm finding within the Health Practice Act, in Section 15 of the Health Practice Act, a person who operates a healthcare facility shall ensure the registered practitioners practicing at the healthcare facility have malpractice insurance or indemnity cover. And it needs to be, and then it goes on to say, ensure the healthcare facility is covered with adequate liability insurance. So that's all of Section 15 deals with the insurance requirements, right, and the malpractice insurance. And then there's also Section 27A, subsection 4. A practicing license shall not be issued to a registered practitioner unless the council is satisfied that they have adequate insurance, malpractice insurance, liability insurance, and other relevant insurance or indemnity cover from an authorized insurer. Authorized insurer refers to the Insurance Act, which means that it would have to be a local insurer that is licensed by SEMA, by the Cayman Islands Monetary Authority. And then it actually, there is an offense in Section 27A, subsection 7, which says a person who contravenes this without and practices without having adequate malpractice or liability insurance commits an offense and is liable to a summary conviction or a fine, and on summary conviction to a fine of $25,000. So there's a lot of insurance pieces within the law. It speaks also to the power to make regulations, which will, so the SEMA is allowed to actually create, the Health Practice Commission is actually allowed to set what the malpractice threshold needs to be. So I think that may be what we were speaking to. I don't think it actually speaks to any relationship to health insurance, which is actually something that,
or something like that.
no, there's no, that would be like the way that it would be titled in, like it would be bringing in the other act. Grandfathering in would mean that we would bring in the other act. And the only reference that is made is to the Insurance Act, which is, of course, what SEMA is the regulator for.
Okay. Now, I know we only got 15 minutes left. We got a hard stop for 7 tonight. There are some challenges, and you were talking about the gaps and underinsured persons. Please let's get into that. Who are they and what are the issues?
So we have several issues. One is I've already identified. I'm looking for my notes real quick because I think I'd sent you some of them, right? But one of the things that I think I've already mentioned is that we need to have more effective, we need to have some form of financial accountability. So in other countries, when a business is going to file their taxes, they have to make sure that their financial information is correct, right? And that their books are kept properly. In Cayman, we don't have that requirement. So where there is no law that requires you to have some form of financial standard or proper like financial conduct, you're allowed to just get away with not doing it. So then when the government reaches out to say they'd like to increase their fees and they ask to see your books, you don't want to show them your books, or you don't have books to show them, or whatever the case may be. So I feel as though without the data from the healthcare provider, we are not making good financial decisions for our country when it comes to healthcare. We need to be collecting proper data as to where this health insurance spending is going, because the health insurance provider can only increase and increase and increase if claims are going out and going out and going out in increasing amounts, right? So that's where your premium is coming from. Without us knowing what the actual underlying problem is, health insurers are submitting their financial accounts on a monthly basis. In some cases, certain types of financial information is submitted on a monthly basis. Some of it is annual. This is full transparency. But if we don't know where that money is going when we're paying it out, and we are not setting standards for how that is being used, then we will always be seeing an increase. We will always be seeing an increase until we actually have insight into where our spending is happening, how it's happening, and how then we can make good decisions, informed good decisions about how to control it. But there are also a couple of places that I would actually want to speak to. And one of the things that I think Cayman does well is children.
Mm-hmm.
Right? We take care of our children in our Health Insurance Act. We take care of our children through cynical. I feel as though the dependent requirement for coverage is actually one of the things that is working in our system. However, just like parents are being underinsured by only being able to afford a certain amount of health insurance because your premium is constantly going up, the children is flowing down to the children. But the actual access and sign up for children within Cayman, I think, is actually going quite well, right?
Okay.
However, our retirees are in danger, in my opinion. Okay. So government has a really good system for, well, and I think, I'm not sure that this applies to all civil servants. I think there's certain requirements that you have to meet. You would know this better than I do, whether it's tenure or seniority or whatever it is, that would allow you to be covered as a retired civil servant on a cynical plan.
10 or more.
10 years or more, right? So what happens if you've only been with government for 5 years and you retire? Then you have to go and buy health insurance. And standard health insurance contract is probably all you're going to be able to afford, because even that will cost you upwards of $4,000 a month. And if your pension is only $800 or $900 or $1,500 or whatever it is a month, where are you going to get that from? Correct. So then you see a lot of people, what I am really nervous about, because of course, my parents are boomers, right? Like young boomers, they're kind of like on the cusp, but there are a lot of people who are, that whole generation of baby boomers are retiring. And that retirement group right now are incredibly vulnerable because they are the largest cohort of retired persons in the history of humanity, in the known history of humanity, right? And so they're now retiring, and a lot of them do not have access to health insurance, right? Because they are either private sector employees who don't have that option, and or they were not employed by government for a certain period of time. So the scary part for me is that in the private sector, the only thing that's available to a lot of these persons is a sick plan. And when you're older, you need an outpatient benefit that is adequate. Several years ago, I was part of a group of insurers that did an investigation into whether or not there could be a standard health insurance contract created for retirees. And it was challenging because some of those retirees have dependents, and the types of benefits you want to take out of that plan would be things like pregnancy cover and some of those, those things like clearly like your newborn. But some of those old men are marrying young women and having children. So you have retirees with young babies. So the reality did not allow for the creation of a specified plan, and the pricing at the time was $500 a month. 500 something dollars. It was somewhere in that region, right? Somewhere in the $500 something a month, 600 maybe it might have been. And so the government thought that was not really sustainable. We'd be better off sticking with the standard health insurance contract, if I remember correctly. And this is a while back. This is history now, right? But the challenge is that we still haven't dealt with it just because we haven't selected that plan or that plan of action going forward. So what we're seeing is that a lot of our elderly who are in Cayman and retiring in Cayman are having to become what we call medically indigent.
Which is one of the definitions that were recommended for the revision.
Indigent is not even properly defined. Exactly. Correct. So that's one of the things that you were working on. I remember. Correct. So medical indigency means, okay, so let's just be clear. An indigent generally, so back in the 80s and 90s, we would call them social services, right? Social services. Then it became NAU, the Needs Assessment Unit. Now they have a new name. What do they call them now, Sabrina? It's
a long acronym about families and go ahead.
Yeah. It's not DCFS, it's the other one.
Yeah.
There's another one. But and it only recently changed. I remember it changed like in April or something. It was like right before the election. So that becoming a client of social services /NAU / whatever this new thing is, that social arm is now required for our retirees to be able to access healthcare. and health care, not just health insurance, health care, for them to be able to pay for health care. And that is also limited, and it's actually backing up. I think it's really cumbersome. There needs to be a much easier way to get this benefit. When I look at, I have family in the US that are on like Medicaid, Medicare, like they're older people that are like using really, they have access to really good benefits in certain parts of the US. They're in Louisiana. So Louisiana seems to have gotten that under control. But they were describing to me how easy it was with their provider to sign up and access and so on. And I just thought about the lines that people have to stand up in to qualify.
The Department of Financial Assistance.
There we go.
Yeah. CE Bank said it.
Yeah.
I pulled it up. I was just giving you a break.
Department of Financial Assistance, DFA. Right. So that our elderly are a big vulnerable population. Another population that I actually consider to be quite vulnerable as well is our long-term disabled, because long-term disability, I think the law changed and allowed for us to support them better. But the challenge often is not just that, like if you're not in like in one of those like if your long-term disability is mental, for instance, and it's not super obvious, right? It can be harder to qualify for long-term cover. So I actually think we do pretty well with our long-term disabled folks who are Caymanian, because Cynical, generally speaking, supports, and there's also dependency is allowed to extend beyond 30. But for those who are not, for persons who are here who are not long-term disabled, who are long-term disabled but are not on that, don't have Caymanian support in like the Cynical social coverage, then that ends up being problematic. You know, and as our population changes and shifts, and we have different guest populations working here, you know, there's also the vulnerable who, I saw a Filipina lady had a premature baby, and in one of my previous years, and I remember my heart breaking. She was on a standard health insurance contract. The baby needed to be flown out. They couldn't send the baby to the US. They didn't have enough funds to send him to the US. This is, by the way, this has happened multiple times. So this is not identifying information. Okay.
Yeah.
And I just remember thinking, oh my goodness, we are so blessed that we are here with our families at home and not thousands of miles away in a medical emergency. And unable to pay for that care and not able to have the coverage for that care when we need it. So our vulnerable populations, there are some of the lower on the socioeconomic spectrum that are actually still very vulnerable to underinsurance. And, you know, we're talking about and as I know we only have a little bit of time left, you know, we're talking about how the minimum wage actually doesn't affect as many Caymanians. That standard health insurance contract is also not affecting as many Caymanians. The inadequacy of the standard health insurance contract is not affecting as many Caymanians as it is our guest workers. And for those that have, like, particularly, it leaves them particularly vulnerable when it is a woman of childbearing age.
Okay, we got a caller. That would be the last caller, if you don't mind. Good evening, caller. You're live on Sabrina Speak.
Sabrina, and good evening to your lovely guest.
That one too with you. You put the hairs at the end.
Oh yeah, I am up. I speak the truth, and the truth has to be told. The financial assistance unit. It's that in itself needs a revamp, unfortunately. I am one who is under the indigent, okay? Because I have a medical condition that I get no other insurance would insure me, okay? I'm HIV positive, been for almost 13 years. What I had to go through to get Cynical approved indefinitely.
Yeah.
You ask every 3 years. You ask every 3 years, and you get told, "Oh, this is how the system is. This is how the system is." And the young lady, the nurse at the time in charge of the HIV program at the hospital. I'm not going to call her name, but she's very well known and a very well put together young lady, and fought for persons like me. But I will tell you, it took 10 years. And 2 years ago, I sent an email to what was the, I guess, DFA, Department of Financial Assistance, to remind them October was coming. This was August, and I needed you to put in for my 3 years insurance. A couple of days later, I get an email. Oh, you don't have to worry about that because as of June the 7th, you were granted indefinite. 10 years. And the only reason it changed was because we had a different minister at the time. And
Feel like they were waiting for it to go away. Crazy, right?
Someone was saying somebody took a list of who was on cynical and indigent and did not have indigent. I wasn't indigent, but I didn't have full coverage of indefinitely. And I kept asking this question over the 10 years. What is it going to take to get it? You waiting for me to die? Because I'm a person, I take care of me, and I go to see a doctor twice a year for blood work. That's it. I don't abuse cynical, nothing. And I sent back and I said, wow, that is such an unwelcome and an unfriendly way to tell me that after I have fought for 10 years to get it, you have just done it. It was done. And the way it was done, you didn't have the courtesy to even pick the phone up and call me. I said, you all must have been waiting for me to die. That's all I can think. But to take care of myself, I have never abused cynical from the time I was given it. Never have. I eat healthy. I try to do all I can do. I exercise daily. But the struggle just to get an answer as to why it was not done, it to this day, it makes me wonder. I've heard stories of person in charge of FAU now. Insurance was given out to people indefinitely, all the time. Friends of this one, friends of that one. And I was like, why did it take all of you so long to realize that I wasn't going to die? I laugh at it because I don't abuse the insurance. I go to the doctor twice a year. And it you sit down and you try to figure out, well, why couldn't I get it? Why you make 10 years go by? Even when I was working and had my private insurance, I didn't abuse my insurance. I paid out of pocket for mine. I didn't even use the insurance. And I would go for a physical once a year. It needs to be changed somehow. I don't know if that's the word for it, but it needs to be updated. And the person's dealing with it at FAU, because it has to go to them, and then they send it off to cynical, and then when you call back, they tell you, oh, it's not us that approves it. And sometimes the attitude you get from people, I said to the lady, I said, ma'am, I went back in the email, I said, ma'am, can you please at least send me the letter on your letterhead stating that I have indefinite insurance? Because I have my card, but I want the backup paperwork.
Right.
Because I'm Caymanian. I was taught in biking. I want my paper trail. I want. When it was sent, I couldn't even open the file. I had to request it back. It's like I said to myself, "Who's sitting behind this desk doing this job?" And you just have to ask yourself, if I am just one story of what happened to me as a Caymanian with what I have, just one story. Imagine what else is going to happen. And I'm going to just say this and leave it there. I remember the day that it came out that NAU at the time said you could no longer use your cell phones in the office. I tell you why that happened. You want me to tell you why? I was there the day a couple of years ago when that elderly came and young lady was standing in front of them. And she said, what do you mean you want my cell phone number again? I've had the same cell phone number for the last 20 something years, and you have it, and all you haven't called me. And she looked at the young lady at the counter and she says, well, I can tell you something. If this is what I got to go through, I'm done with you. I ain't coming back. That was why that policy was implemented. And it is sad. It is so sad to see how some Caymanians, when they have a dire emergency like I did, you know, regardless of the fact of how it happened, someone lied. That's how I became HIV. I was in a relationship, someone lied. And you have that stigma to deal with in society. Having to deal with going to the hospital. And I will tell you, for years I went to the hospital. It was one particular young lady, and I opened up on her, and I made her know that I knew who Lizette Yearwood was. And I sent the email, and I said, if this woman scorns me again, I don't want to take my insurance card and my voter's ID, you're going to hear from me really bad. So you pull her aside, you put it, do whatever you have to do, because I'm not going to be discriminated in this country. And it goes to the point of common sense. God makes us all be born with it. But why are you going to drag out a process for me over 10 years when you could have said, here you go, we're giving you insurance indefinitely because of what you have. No one else is going to insure me. And yet you drag the process out because the process was flawed from the beginning, unfortunately. And I think a lot of it has been cleaned up. But there's still a lot more cleaning up to do because the way in which the Department of Financial Assistance, the management, and the officers who speak to people like me sometimes, when I told them I had osteoarthritis, you know what I was told? You have insurance. You got cynical. I went back to them. You know what I said to them? Cynical insurance cannot solve osteoarthritis. Read up on it. It's a degenerative disease, and it's no cure for it. You can. I manage it. You know how I manage it? I was put on 100 milligrams of defloniac, a pain pill, and I said no. I'm taking one medicine with 3 already into it. I don't want no more. I Googled it. And from that day, about 3 years ago, I started clean eating. Everything is organic, more expensive. I don't drink sodas. I don't use sugar. And I will tell people this today. I ask the question all the time, what is the most deadliest drug we have out there? And I get told food and I get told alcohol. And I looked at them and I say, sugar is the worst. It's the most deadliest drug. If you get it out of your system, if you stop all of that crap, all of this nasty bread with all of these things causes inflammation. Let me tell you, young ladies, Miss Sabrina and your other young lady there, Miss Annikki Brown. I don't take that medicine. I'm taking it in years. I put cinnamon in my coffee powder in the morning. I use when I want sugar. The supermarket sells some really good sugar. Coconut, organic coconut brown sugar. 1 teaspoon got 4 grams of sugar. Go look at what the regular white sugar has. So it comes from educating yourself, because I educated myself once I became HIV positive. I really educated myself on it. And I learned everything I needed to know. I learned what I need to have and what I need to have. And the information for my osteoarthritis don't bother me no more because I do clean eating. And what else goes with that? Sleep, adequate sleep every night. And I exercise, walk, and stretch every day.
Caller, do you mind if I just respond to some of the things that you said?
No, go ahead.
Because I first of all, I love that you mentioned the wellness, right? I feel like you sounds like you are one of those people who an insurer definitely wants to have on their plan, because you are one of those people that's actively taking care of yourself. You're doing the research, you're learning your body, which is the same thing I said to, we were talking about emergency services earlier. Very similar. By the way, Sabrina, my laptop gonna die soon. But I
Well,
also
we're
wanted to
overtime.
speak.
We're in
I know we are.
overtime.
I'm gonna be super short, right? I'm gonna be super short with my response. But I
Yes,
think
young
you've
lady.
highlighted a couple of major issues that I would want to, first of all, deal with. One of them is dignity. I believe that everybody has the right to be treated with dignity, and healthcare in particular. It is such a vulnerable place to be. And we need to be making sure that we treat everyone who has any kind of condition, no matter what, should be treated with
Yeah,
dignity. The second
with
thing that I wanted to
respect
say
and
to you,
dignity. Mm-hmm.
we were the first insurer, and my team was the first insurance company in Cayman to cover
Mm-hmm.
HIV,
Mm-hmm.
cover HIV and AIDS. And
Mm-hmm.
I remember feeling so blessed to be able to do so, because we were allowed to do so
Mm-hmm.
because we had an internal reinsurer, our reinsurance company, who was reinsuring us, who kind of like the insurance company for the insurance company was able to we had some say over how that could go. The challenge is that
Mm-hmm.
it is now in
Yeah.
Cayman, it is majority covered by government. But I think that the answer that you're speaking to right now, the main issue that you're speaking to right now, is that we
Mm-hmm.
have I agree with you that the current system and the way that we deal with medical indigency is broken. But I think it's because we are not separating medically indigent from indigent. So you're having two separate types of thinking being done by the
Mm-hmm.
same team. And there needs to
And they're
be a
clashing and not able to
separation.
solve nothing.
Yeah. So there needs to be a separation. There needs to be a team that is dealing with medical indigent, just in the same way that I cannot claim to be an expert in house insurance or in
Right.
Mm-hmm.
motor insurance. I am a health insurance person. Same, there's a very similar distinction between the assessment of the needs of persons who are medically indigent and not medically indigent. But I really have a lot of hope for us, because I think we have a system that can work if we actually look for these gaps like the one that you've identified and start to
Yeah.
close them.
Yeah.
Sorry, Sabrina. I know we've taken Sabrina over time, and it's just won't kick us
I
out.
could get
I know,
fired.
but
I could get fired. I could get removed.
one other thing, when I went to the hospital about three years ago to have a surgery, there was a Caymanian, and it was sad. It was a Caymanian EMS that brought me in, and I could barely, no, it wasn't a surgery. I could not breathe.
Mm-hmm.
And I watched lying in that bed till 10 o'clock that night before I went up to medical ward to be admitted, because there were no beds. And I watched as that Caymanian EMS young man wheeled the patient in, and he grabbed the nurse that was taking care of me. And my curtain to my room in ER was pulled halfway. And he stood right there, looked at me and looked at her and told her what I had and to be careful. And I went off. I really did go off. And I told Miss Lizette Yearwood some of everything I had to say. And I keep going back to this. Respect is earned, bought in any supermarket. No establishment sells it. No establishment sells common sense. But God Almighty, we're born with that. It's up to us to use it. But when you have someone in a medical field that is your own kind, your own people, discriminating against you, and this was the young lady that wouldn't take the IDs was Caymanian too. That's the problem I have. Because if you are there to provide medical services to me, doesn't matter what I have, who I am, you're supposed to show everyone respect and give us our dignity. Because like I told this Miss Yearwood, I don't beg for nothing. And God forbid what happened to me happens to anyone else. But I am not going to sit down and allow anyone, when I take care of me, I have took responsibility for what happened. I don't bother anyone. I want my respect, and I want you to understand that you're going to take care of me whether you like it or not. Because if you don't, when I need the care, you're going to hear from me from the loudest mouth that I have. I'll say the nicest words, But we have to come to a point in this country where having what I have, it's not it's not this mental thing, but oh, don't want to touch what this person is touching. And we got to come away from all of that. And it all ties into when you respect someone, it does not matter what it is they have. When you're in a medical field, you are there to provide a service. And when I got in that ambulance, I told both of them, the driver and the young man that was taking care of me, I said, this is my docket number. This is my date of birth. And I have HIV. I'm undetectable. And I've been that way at the time was almost for 11 years.
Mm-hmm.
And the first time, because it was 2 trips to the hospital before I was admitted, they called it in and let them know. And they did a COVID test and I was negative. But I had a chest infection. No one knows to this day how it came about. I still believe it's the COVID shot because I was perfectly fine up till then. And I caught the flu in the hospital and I had pneumonia. And the audacity of that young man to treat me that way didn't sit well with me. And I made it known that nothing better not happen ever again. But to get back to the point, we have to speak up when we see something not going right. And if it takes this long for me to have gotten cynical, when I'm doing everything I'm supposed to be doing and more, what about my other Caymanians that I see when I go to the clinic that are going through the same thing? The system really needs to change. And I would say this to anyone involved in healthcare. We all at some point are going to become or get to where we need the services of health services for whatever reason. And we all would like to be treated with a little dignity and a little respect, because I command respect, I demand it because I give it. And that is the way I live my life. I respect people, so I expect to be respected. So I'm going to leave you both there. I'm going to say thank you. Miss Sabrina, you know I keep telling you your topic, right on par.
Thank you.
You keep doing what you're doing. You keep being you, because once you shine, nobody can take that shine away from you. Let your light shine bright.
Thank you, caller.
Because you, ma'am, I have the utmost respect. I have had before, and I have even more respect. And Miss Annikki, I have all the respect for you.
Thank you so much.
Thank you for being the Caymanian women. And I'm calling you young ladies because you're still young. Because I'm almost 55, but no one can tell. Besides my little balding spot and my gray hairs. When I shave it, nobody knows my age, but I'm almost 55. So you all keep doing what you do, because I am one Caymanian man that have the respect for me and my people, and I demand the respect because I give respect to people. So thank you, and God continue to bless all of us in Cayman and the Cayman Mile Road, everyone on it. And thank you and Miss Sandra for bringing topics that are meaningful, discussive, and we get to dissect them, and the public gets to understand, because some of us in the public don't really know a lot about these things.
No.
I know about it because I've had to learn it. And I thank you. God continue to bless all you and these Cayman Islands, and keep doing what you're doing, because believe you me, it's not going unnoticed. We Caymanians have finally got a voice, and we are speaking up, and we are saying things have to change, because this is home. I can go anywhere in this world with my passports, but when I tell my family, it's coming home day, it's coming home day. And there's no better place or airline to come on than one of those 9 aircrafts that says Cayman Airways. When that makes you smile no matter where it is. God bless you, and thank you very much.
Thank you, caller.
Have a
Much
good
love.
night.
God bless you.
Yes.
Bye-bye.
Thanks. Bye-bye. Nikki, I wanted to put context to the to Lisa's comment, which she provided, and I realized
Okay.
what's happening to the grandfather clause. What had happened what happens when somebody works for an organization, let's say for 20 years, and for whatever reason they've had to resign. Isn't there something in place that, let's say, medical coverage should continue, or
No.
that is based on terms and conditions of the contract? But because of the length of time that you're with an organization,
No.
if they choose to resign for whatever reason, it's that's where that was coming from. Is there something in law that grandfathers them for medical insurance coverage?
No, there's no such thing in law that that requires a continuation of medical coverage based on tenure. However, there are a few large employers in Cayman who have created retirement plans that are based on tenure. So if you've been with the company for a certain period of time, but it's not in the regulations, it is not in the law, it is not required by law. And for many reasons, I think a very big part of it was an acknowledgement that the majority of our population will not retire here. Right. And we have medical services that are designed for the aging population that will retire here. And so to facilitate access to healthcare, this is what I think. I'm not sure, but this is what I assume is the reasoning is that, we are attempting to protect the system and not burden it by opening us up. So for instance, snowbirds flying down, right? So that was one of the things we talked about when we were talking about the health insurance law, that, do we want to make health insurance so accessible and that we become a retirement destination, right? Do we really want that?
Happening. That's happening. People are not living here.
It's happening, but it's people who can afford it. Right, people who can afford it. It's very much an economic. Yeah. So we are the fear was that cynical would be drowned with persons who could not afford the care and the health insurance.
No, but in this case, it would be a born Caymanian, and in this case, I don't want to go personal, but
no, I hear you. I understand what you're saying. I see where you're going.
The expectation.
Looking for extended cover after retirement.
But they've resigned. That's what the problem is. It wasn't a retirement.
But you see, even there though, Sabrina, even if they retired in the private sector, there would be no continuation of cover unless the company had created that. It's only in the public sector that exists.
And in this case of a resignation, that makes it even more complex, I'm assuming.
It could, but I'm not sure. It would depend on what those internal policies of the organization would be.
And the terms and conditions of a contract.
And the terms and conditions of the contract, and also the terms and conditions of the contract between the employer and the health insurer. Because I have actually seen employers put things into their employment contracts that the health insurer is not aware of and would never have agreed to, because the reinsurer would not have allowed the health insurer to agree to it. So, it's important for everybody to be on the same page. The employer, the health insurer, and the employee all need to be on the same page and understand exactly what those terms are.
Gotcha. Any wrap up? I gotta go. Wrap up.
I know you gotta go. Listen, man, I love what we do, and I think I have a lot of hope for our healthcare system. I think it is possible if we are able to put all of the pieces into place to bring more integrity and access to data. I think that we have the recipe. We just don't have all of the ingredients yet. And I think, but even so, I think we're really ahead of some of the even other sophisticated jurisdictions throughout the world are not as sophisticated as Cayman's healthcare is. I would also just want to leave one last comment that I just want to your listeners to keep in mind. Cayman probably has more health care providers per square mile, I think, than any other island on the earth.
Oh, wow.
So clearly something is working and people are getting paid.
We just got to make sure we can
just need to decide if we are paying for the right things.
Yes.
Okay. We just need to be clear that we're paying for the right things. and that we are designing, being very practical and sustainable. And I think at this point, the gaps in our system are not allowing for us to be that.
But look at here, I mean, in our very own constitution, it proudly states that we are a country that provides a comprehensive healthcare system. That's in one of the preambles of our Constitution Order of 2009. So that is actually one of our fundamentals in that preamble. There's not a specific section, but it's in the preamble. So that speaks a lot about our jurisdiction,
our values and our goals. Yeah.
Yes.
We've done some good things. We've done some things right. We just need to keep maturing our system. That's it.
Correct.
That we need to mature. We need to grow up and keep going and closing gaps as we go along. I think it's unrealistic to talk about government taking over coverage of children. I think children are actually very well cared for now. There are gaps, but those are not actually specific to children. There are gaps in that there is an underinsurance of a certain part of our population. And there is not a clear goal or clear plan as to how we're going to care for our retirees. If we're going to say that there's a population that is actually more vulnerable, it is our elderly. They don't have parents to take care of them. They're actually not defined as dependents by our health insurance law. So, if anyone is actually being left behind, it's our elderly, and we need to start paying attention to them, because that's going to be us soon.
Yes.
And even if it wasn't, it's going to be us soon,
Yeah. Yeah.
So thank you so much for this.
Thank you. Thank you.
It's been a pleasure. I know we only decided to do this today, so this is
I just thought it was
coming by the seat of my pants.
Correct. No, but I think we were able to cover a lot of ground. You can see by the feedback you heard from the callers, and we're still getting questions. But no, I want to thank you, Annikki, for taking time out so quickly for your incredibly insightful and sobering discussion here. Always very good having you as a guest. And it's clear that while Annikki, our healthcare insurance system has a long and a strong foundation, that significant challenges still remain, but it's not like we're not actually making strides. So it speaks a lot. It speaks a lot about, exactly what I alluded to with our Constitution. It's a fundamental promise to our people. And what that last caller described, that is our promise. And that speaks a lot. So at the end of the day, we just got to keep working at it, and let us all do our best to work together to continue to create a system that's not only survives, but it thrives and everybody benefits. And, let the foundation be that it's one that really honors that preamble in our Constitution, and that to promise comprehensive healthcare system for every member of our community. That's key, for every member of our community, ensuring that absolute no one is left behind. But again, thank you again for joining me. Pleasure. And thank everyone for being with me. And I just want to wish everybody a good evening. Until next time, Nikki, God bless you.
Take care. God bless you too, darling. Talk soon.
Yes. Well, there we have it. Yep. Oh, what did I do? There we have it. We come to an end of our next show. I want to thank everybody for joining me this evening. And no, Miss Melita, it is not going to be something that you can expect as a trend. You're too much trouble. I really got to do better at timing. And I don't want to get off to a bad start, to be honest, even though once I know it's engaging and you guys are enjoying, obviously, the conversation here. But yeah. It's not going to be a norm. I want to just, again, thank you all for sticking with me, for your feedback, for your participation. It makes it all worth it. And again, until tomorrow evening, please be careful. I want you all to stay informed. I want you to stay vigilant and take care, not only of yourself, but each other until, as I continue to build and evolve this space along with you. Until tomorrow, love you lots. God bless. That's a wrap for today's edition of Sabrina Speaks. Thank you for tuning in and for being part of the conversation. Remember, the dialogue doesn't stop here. Stay engaged, stay informed, and most importantly, stay empowered. We'll be back tomorrow at 5 p.m., same time, same place, right here on CMR TV and radio, where your voice matters and your truth is heard. Until then, K-Man, take care of yourself and each other.
That's it for today's edition of Sabrina Speaks, where your voice matters, your story counts, and your truth is always welcome. Join us weekdays from 5 until 6:30 p.m. right here on CMR TV as we dive into the topics that matter most to you. Catch the show live or on demand at cmrtv.com. And don't forget to follow us on Facebook, YouTube, and Instagram so you never miss a moment. Until next time, stay informed, stay engaged, and always speak your truth.